everybody. Recording live from somewhere. This is Zach Couples with episode number 131 of the Movement Debrief. And today, folks, my neck, my back, we'll stop there because we're going to talk about lumbar spine troubleshooting. If you got someone with a shift, you got someone who's got a deep arch in their back, don't worry, Zach has your back. Because your boy, Big Z, has got a bunch of questions that have been asked by the people. They will be answered for the people by this people right here, Famericanized Fam. Without further ado, let's debrief, shall we? The first question comes from, I hope I pronounced your name correctly, so I apologize, Kresimir. Here's what Kresimir asks. What are your thoughts on someone who has a combination of hyperkyphosis and hyperlordosis with both rib flares? Could these be due to mouth breathing as a compensation for improper breathing patterns? And how would you try to improve it? Awesome question, Kresimir. So let me tackle one piece first. What is the cause of someone who has hyperlordosis, so a deep arch in their lower back, hyperkyphosis, a deep curve in their upper back, and rib flares? Rib flares are when the lower rib cage is prominent. What causes that? Here's the answer. I don't know. There's probably a lot of factors at play as to why that's caused. I'm sure there's a combination of genetics, epigenetics, and environmental or movement, or not even movement, but environmental-based factors that lead to someone exhibiting a certain posture. And there's a great video that my dear friend and father, Daddy-O Pops Bill Hartman, put out this week. This is very timely. Like, check it out. I'll link it in the show notes, which, of course, will be found on zachcouples.com/lumbar. But check that out. Like, we can't, and I will echo what he said, we can't necessarily obsess and worry so much about static postures because there are some things that we can't change, and that's how we look to some extent. If someone's exhibiting a particular posture, there's likely some structural bias that predisposes that person to having that. So unless you're going to change your structure somehow, you might have that to some degree. What is more important in this case is restoring the available movement options within that structure. In the case of someone with lordosis and rib flares, if you can't minimize the rib flare or reverse your lumbar curve, then that's a problem. But achieving a static positioning that we think is good is less desirable because we are not static creatures. We are creatures who are meant to move. So please move. But what would you do about someone who has a large lordotic curve and rib flares and maybe they have a hard time reversing that? Well, I'm glad you asked. The big thing you have to do is you have to find some type of position that allows that person to achieve the stack. The stack being, and this is where someone who's got a big lordotic curve may have a hard time, would be achieving some degree of posterior tilt, exhaling the lower rib cage so the ribs drop down. That, in theory, puts the thoracic and pelvic diaphragm atop one another, and that gives you the potential for movement options in many directions. If I have a hyperlordotic curve where the C shape of the lumbar spine is increased, so you have at least lower lumbar extension, you have a pelvis that's oriented or tilted anteriorly, that person may have a challenge creating the posterior tilt needed for a stack. So that's why that could be problematic if you can't reverse that, because there will inevitably be a reduction of movement options available. We want to see if we can teach someone to reverse that, like your favorite Missy Elliott song. What I like to do for these types of people is, if they are someone with a deep lordosis, you may be better served doing tucking or posterior tilting in the side-lying position, because a lot of times people who have a deep lordotic curve, though it's not always the case, are wide infrasternal angle presentations. And if they're not wide ISAs, they're certainly trying to be because of secondary compensations. If you're unfamiliar what a secondary compensation is, I got a good debrief that I'll link in the show notes. And I'll also link something about stacking because I want you to be able to talk to me. Side lying position is useful for teaching a tuck because you're doing so in a gravity eliminated plane. For example, when I try to do a posterior tilt in the supine position, I have to lift my pelvis up against gravity. That can be really challenging for someone with a deep lordotic curve. The side lying position makes it a little bit easier because you don't have the influences of gravity. If I had to pick a side, which you're supposed to do nowadays, but if I had to pick a side, I would go to the right side, and the reason why that has to do with the inherent asymmetry that we have within our body. That may predispose us to having somewhat of a leftward force that we're constantly fighting against. Again, check out Bill Hartman. I'll link him in the show notes. He is way better versed in that than I am. But right side seems to be a little bit more effective for teaching this in that regard. So with that person, get them tucking. Make sure you're achieving a full exhale. Those two pieces right there, if you can get a good tuck and you can get a good full exhale, ought to teach that person to reduce the lordotic curve, and it should help them reduce the rib flaring. Because the rib flare is there because of the lordotic curve. That's one reason why the ribs are a little bit more prominent, is because the body is shifting its center of mass forward, and that's what makes the ribs more visible. If you do those things, then, and you can breathe in that position, maintaining that stacked position, you will get the potential to have multidirectional expansion in the upper thorax. That can improve the dynamics of the spine in that area. If you got someone with a hyperkyphosis, although having a true fully formed kyphosis is a bit rare, what I often see is a segmental kyphosis with flattening above and below. That will give you some expansion in that area to hopefully normalize the kyphotic curve from a movement perspective. I can't emphasize that enough. That would be the very first place that I would start. From there, it's a matter of trying to utilize as many different positions as possible to teach that person to keep that stacked position. Another thing that they will have a hard time with, but I would say is the pinnacle of reducing the lumbar curve, is being able to achieve a full squat, staying as vertical as possible through the ventral cavity as you can. With a anterior pelvic tilt and a lordotic curve, that person's pelvis is going to have a tendency to be pushed more posteriorly. We don't want that. If I can do a squat, then I can get maximal posterior tilting, and that's going to go in the exact opposite direction of the person with a deep lordosis and rib flare. And those would be the places that I would start someone with a hyperlordotic curve, rib flares, and kyphosis. To summarize, your amazing question, Krasimir, hopefully I pronounced it okay, but I got work to do. We don't need to concern ourselves too much with static posture. We are mobile creatures, so move and groove. You want to teach this person, however, to be able to reduce their lordotic curve, reduce the rib flare, reduce kyphosis, or actually make the kyphosis more uniform if you can from a movement perspective. The way you do that is, of course, teaching the stack. That has to happen. Side lying position's good. Your terminal exercise is a squat, and then you want to fill the gaps in between those. Amazing question. Jim, HDSN on IG. What if the lumbar spine looks relatively flat, flexed, and the arch starts at the TL junction? Okay, this is a very good question as well. You need to confirm what you're seeing testing-wise, because even if it's flat, usually that's because of a secondary compensation. In the case of a wide, in a narrow, there should be some flexion in the lumbar curve just because of the counternutation of the sacrum, or at least it may appear that way. But that you can still have some compression in that area. If you actually look at Stu McGill's book, Low Back Disorders, I think it's called, I'll link it. He looks at the function of the erector spinae in that area, and it actually is a shear reducing thing, and it may not increase your lordosis, but it may actually compress that area. So you can still have restrictions posteriorly in the lumbar spine even with this presentation. How would you know that? If this person has a loss of hip flexion, that's a telltale sign. And by hip flexion, I'm saying they can bring the thigh all the way to the chest and compress down without any pinching. And you see the pelvis tilt posteriorly. A lot of times, if you're testing hip flexion and you got someone who's super flexible, they can get hip flexion all the way to the chest, but you'll still see an arch in the lower back. I've seen a few of these cases actually. A lot of times they'll still have pinching in the front of the hip when you get to that end range, but it's something to consider. You can't always rely on visual presentation to make decisions because we don't know what they look like from a movement perspective, and this is the issue of statics. Being static in one position or one situation, standing, chilling like Bob Dylan, may not be the same if you're moving. I'm sure we've all seen this. Someone who has a deep lordotic curve, but then all of a sudden they can do something amazing when they play a particular sport. That's why you have to look at the task to really see what that person's capabilities are. However, if you have someone who is classic narrow ISA, where they have a flexed lumbar spine and their flexion, abduction, external rotation measures are clear, you want to do things to drive hip extension. Working at 0 degrees of hip extension and beyond while keeping the stacked position is usually a worthwhile way to restore some semblance of normal lordosis in the lumbar spine. Awesome question. The next question comes from Alex. Here's what Alex asks. Hey Zach, can you talk about chronic lateral shift, your take, management, and prognosis? Toughest group for me. This is a tough one because a lot of times people who've had a chronic lateral shift usually had some type of issue either at the disc or the nerve root. For those of you who don't know what a lateral shift is, that would be where you have someone who translates their top half to one side and their bottom half to the other. And usually that's a compensatory mechanism to help offload an issue either at the disc or the nerve root. That's what a lateral shift is. You a lot of times see that in radiculopathies where you have symptoms going all the way down the leg, and it's actually a offloading strategy that your body uses to protect the area. In acute situations, if you got someone with a hot disc or a hot nerve root and they have symptoms, you may not want to correct the lateral shift, because that is likely there to allow the area to heal and not get stressed and strained. It may be that if you correct the shift to normal, there's going to be increased compressive forces on the nerve root, problems ensue. So be careful with that. Wait until the inflammatory process has calmed down a bit first. And the inflammatory process usually lasts anywhere from 3 days up to 14. Well, it's usually 3 to 7, but I would give someone 2 weeks personally. And that actually may involve utilizing some more aggressive measures in the short term, and that could be referring someone to get some anti-inflammatories and steroids to help calm the inflammation. If the nerve gets too compromised in this situation, so you're not getting any changes in pain, anything like that, then you have to be careful, because what can happen is you could potentially have longer lasting nerve damage. That's why if you have someone with this, you need to check reflexes, you need to check sensation, you need to check muscular weakness. If any of that's happening and it's getting worse, sometimes a steroid is the fix. So give them some high dose anti-inflammatories, refer them to someone who knows how to implement that stuff. That's the first thing. But let's say we're past that. The tissues have healed, so to speak, and now we have a situation where we have someone who has this chronic lateral shift and we need to unshift them. I want you to think about what's going on here from a stacking perspective. Let's say that my lateral shift is, in my case, to the left. So my top half is going left. What's happening is the left rib cage is actually flaring outward. It's almost like a side bend towards, but a translation away. So I have this, the rib cage essentially doing this downward tip on the right and this upward tip on the left, and then shoving to the left the whole way. And then what I have on the hips is I have an oblique movement of the hips. In this case, the left innominate is going to be a little bit higher and the right innominate is a little bit lower. And that's the offloading strategy that your body uses when you have this type of lateral shift. Therefore, if we got someone who has a chronic lateral shift, we need to basically flip-flop that relationship. I need to do things to change the obliquity of the pelvis, or be able to get that person to go oblique the other way. And I have to drop the lower rib cage on the left-hand side. Your first line of defense, broken record party people, is to stack. And you might do something unilaterally to achieve that stack. If you got someone who, even though it's a chronic condition, and they still have some symptoms, or they can't move well, or they're very sensitive, putting them in a left side lying position, if it was a left shift, perhaps with something underneath the left abs to encourage the dropping of the rib cage or the compression of the lateral lower rib cage, that actually might be a great way to start this process. And you can just have them breathing in that position. The nice thing too is, because remember the shift, I'm shifting away from the issue, is when I compress that left side, I'm going to get expansion on the right side. So that can actually help offload the structures if they're still a little bit sensitive. Perhaps you have some spinal sensitization going on. And I'll link, if you don't know what that is, I got a great course notes that talks about that. Once you have that, then, and you've done, I would do that first. Then, just like with the lordosis question that we had before, I would work on getting them a squat, because that's going to create offloading throughout the entire posterior spine. That's going to be key for someone who has any nerve root issues, because it's going to increase the foraminal space. Because if I go into flexion, the zygapophyseal joints, or the facet joints, are going to be opened up. So if you can get someone to squat way low, that's going to open up that area, and that may offload some of the structures that are sensitized. If you can get someone to squat parallel or slightly below that, that's when I feel comfortable teaching someone to get their shift together, because that's what you're going to need in this next piece. You're going to need oblique shifting. Pat Davidson's got a great analogy of calling this like a seesaw pelvis. So I want someone to be able to reach one leg down and the other leg up. So for this person, if I'm shifted to the left and I have a right oblique angle at the pelvis, like this, well, now what I'm going to do is I'm going to go the opposite way with that. So what that might entail is doing lateral squats as a terminal exercise, but I also have like a table side stride that I really like, that I'll link in the show notes, that works on creating that same seesaw pelvis position. I would do this on both sides for people, just because one side is going to teach them to offload safely. The other side is going to teach them to load that area effectively. So I would start with that, work to lateral squats, work to lateral lunges while keeping the stack position. And if you can do that, a lot of times that will help restore the lateral shift that you may see. And it should reduce symptoms. With any chronic or persistent condition, make sure that you go slow through this process, because if there was some tissue injury that happened, that area is likely going to be very sensitive. So you want to make sure that you slow cook the brisket, as I like to say. Otherwise, you're going to burn the meat and need a new slab. You want to start with side lying, work towards basic stacking in the squat position to really offload the area bilaterally, then teach side shifting to restore the obliquity movement options that should be available at the pelvis. And a lot of times if you do that, that should help improve this type of person. If you've done that and there's still some sensitivity or some symptoms, that's when I would probably go towards neurodynamics. Great resources for that would be David Butler at the Illinois group. I like Shacklock a lot as well. His book is outstanding for restoring neurodynamics, or the movement of the nerve. I usually only go after that after I have restored movement options, though, because you got to think about this. If I want to do a glide of the sciatic nerve, that's going to involve some degree of hip flexion, some degree of rounding through the spine, and dorsiflexion, plantar flexion. What if you're restricted in those movements? The excursion of the nerve is going to be limited. So maximize the potential excursion first by restoring movement options, then teach the sliding and gliding of the nerve that should happen. Some of my go-to moves are a slump slider. Those are great. Doing a straight leg raise slider, or a simple thing that I like, and I think I talked about this a while back, but if you find a position that's uncomfortable, have them slouch in that position and then just move the head up and down. That's also going to create neural movement, and it should allow them, I think it works more effectively than just your traditional sliders and tensioners that you might program, because it's context dependent to when that person feels symptoms. And that would be the sequence that I would utilize if I got someone with a radiculopathy or a lateral shift that cannot get back to normal. Amazing question, Alex. The next question comes from Mark. And here's what Mark asks. Hey, Zach, hope all is well. I had a question that may be beneficial on one of the movement debriefs, like this one. I was wondering what kind of modifications you may make when teaching the stack and trying to restore movement options when a patient experiences radicular symptoms during resets. I'm having good success with other treatment approaches for controlling their symptom profile, but I'm struggling to address their true underlying compensations patterns without eliciting radicular symptoms. Thank you, Mark, for a phenomenal question. So if you have someone who has radicular symptoms during resets, usually this coincides with flexion intolerance, because when I flex the spine down, that increases tension through the nervous system. You have increased tension through the nervous system, and you got a nerve that's not so happy. Problems can ensue, and you may elicit symptoms. And with a lot of the work that we do, we are utilizing flexion-based postures to increase movement options. So what the heck is going on there? How do I go about improving this stuff? Do I do a bunch of extension exercises and call it a day? That's not where I would go, but I would go somewhere close to that, actually. I've had a few people recently who have had radicular symptoms when I got them into flexion. And a lot of times what I see with this is if someone has A to P compression or concentric bias, front side and back side, so they have multidirectional range of motion loss, what can happen sometimes is they may not be able to get a full flexion or expansion posteriorly because of the anterior restriction. When I move, I need to be able to create a gradient. So if I flex my elbow, the only way I can flex my elbow maximally is if I can create maximal stretching or expansion on the posterior aspect of the joint. If I'm going to fold forward, or I'm going to do a flexion-based activity through my spine, the only way I can do that throughout and distribute the forces evenly is if I can create maximal compression or concentric bias on the front side of my body. If I have a situation where I'm double concentric, I'm concentric on the front, concentric on the back, problems ensue, and that's why you talk to Zach. If that's my situation, I can't create that gradient, and movement is going to be compromised. So I have to create a gradient. Many times, the people who I see who deal with this are people who are wide infrasternal angles who have that secondary compensation on the front side. A lot of times, I'll address that front side first. That may look like doing things to improve pump handle mechanics and driving nutation of the sacrum, either keeping them between 60 and 100 degrees of hip flexion or driving hip extension in that case, while keeping the stack. If you choose those areas, that's a little bit of a safer position because you're not driving as much expansion in the posterior aspect of the body, and that can improve radicular symptoms. I've had a couple cases very recently where I went that route. They had limited toe touches and symptoms, and we cleaned up those symptoms without doing any expansion posteriorly. And I think the reason why is because that created that movement gradient that we're talking about. Because if you don't have a gradient, movement is only going to happen in a compensatory fashion, and we don't want that. So that would be something I would consider focusing on with that. That's really where I would go with someone who has that. So if you've restored extension, adduction, and internal rotation-based measures in this person who is feeling these issues going into flexion-based postures, I bet it will go significantly better than tackling the flexion, abduction, and external rotation-based positions. I'll link a couple of my favorite moves in the show notes that will go into how to drive anterior expansion. Awesome question, Mark. Dan on IG. Zach, what tests would you use to find out if someone needs to get their shift together? What would their test results look like? Good question. When do I shift someone? I will only shift someone if I can get them to, well, I shouldn't say that, but a good rule of thumb is I would shift someone if they can get to a parallel squat or slightly below. Because if you do it any sooner than that, chances are they're going to lose the stack. Tests that I would look for, usually this would be a loss of just like that last little bit of motion. So you might get someone who has 15 degrees of external rotation at the hip, and then you do some moves and you get them to 45, but you can't get them to 60. Or same thing with hip IR. Maybe you get only a 10-degree improvement, but they still need about 15 more. Usually shifting is about clearing those end range restrictions. And that's what I would do. So if you perform your full assessment, you get some good changes, and you're just not getting that last little bit, that's when I think the shift is indicated. Awesome question, Dan. Last question comes from my dude Bryce. Here's what Bryce asks. I'm interested in some version of the gymnastics drill, the Jefferson Curl. Extension from full forward flexion but with hands on legs for those with narrow infrasternal angle presentations. Some say that loaded/unloaded flexion drills are just accumulating tissue damage, but I have doubts, assuming that a person doesn't jump up to loading too quickly. I love it, Bryce. So I will preface, for those of you who don't know what Jefferson Curl is, basically you got a barbell and you're loading over into flexion and you're slowly curling up one segment at a time, extending up. I'll link a video in the show notes so that way you can kind of see what it is. So the issue that Bryce is wondering about basically is flexion and is loaded flexion problematic? I did a whole debrief dispelling this because I don't think it is. A lot of times, and I'll link that debrief, I would strongly encourage you to check it out. In vivo or in vitro experiments, so looking at a hasa. Do you know what a hasa is, man? It's a pig. So looking at pig spines and doing multiple flexions, that is shown to negatively compromise the disc. But the issue is they're quadrupedal animals and it doesn't necessarily match what's going on in vivo. Check this debrief, but again, the research on loaded flexion being problematic just isn't there in humans. So I think it's safe. I think, and a prime example of this is look at Olympic lifters, look at strongmen. They're constantly loading their spines in flexion. Do all of them have severe back issues? Probably not. So I want to dispel that loaded, unloaded flexion is not a bad thing. It's a physiological movement that we should have available. And give yourself credit, human beings. You are adaptable creatures. We can adapt to so many different stressors. I mean, there's people, look at all the crazy sports people do, and they still live and thrive. So to say that flexing and rotating just a little bit is going to shoot your disc out the backside of your body, I think is crazy talk. So you're okay flexing. But now we have to ask, is the Jefferson Curl a useful exercise? I will admit it's not an exercise that I've programmed a lot, if at all. I think where Bryce is going in terms of using it for a narrow infrasternal angle is actually pretty good, because a lot of times if I'm a primary compensatory narrow ISA, I will have a loss of forward flexion because I have an inability to nutate the sacrum. So I could totes my goats see a Jefferson Curl being a terminal exercise for someone with a narrow ISA who has primary compensations. The issue is, I think it's very tough to segmentally control the spine the way that the Jefferson Curl is performed, and I don't think most people have that movement capability, especially if they can demonstrate something like a stack at lower levels, then a Jefferson Curl might not be the best move. But if you have someone who has their base level movement options, they move pretty well, maybe they have a full squat, you can see some curve reversal when they're doing a toe touch, I think it could potentially be a worthwhile move. You're going to be strengthening the tissues in that position, which I think is good. And also, too, it's a more challenging variation of a way to nutate the sacrum or perform a toe touch. So in that case, I think it's something that could potentially be good. What I have a hard time with, Bryce, is I don't know, in terms of the people who I work with right now, who I would program that for. And maybe it's just because I have I just don't have that much experience utilizing it as a drill. But, just me thinking aloud right now, that's when I could potentially conceive of using it as someone who has a narrow ISA, who's got good movement options. They can demonstrate a curve reversal on their toe touch unloaded, and I want to try to progress them at being able to maintain that position. That's when I think the Jefferson Curl is useful. But most importantly, you will not break your back by loading in flexion. But also, too, caveat to that, make sure you're not just, okay, Zach said I can load in flexion, let's go. And, you do 225 on the Jefferson Curl, and all of a sudden you're mad at me because your back hurts. Just like anything, you have to progress the load slowly but surely so your body can tolerate that. An issue I ran into, not with the Jefferson Curl, but with a different move, is the squat, or the squatty squat, as some people call it. Get out of here. But with the squat, I was telling a lot of people who weren't used to squatting that way to squat and try to be more vertical. And these were a bunch of ripped bros who aren't used to squatting that way. And what happened with them is some of them try to change their squat technique. They keep the same amount of weight, and they're saying, Zach, my back hurts. This is BS. That squatting doesn't work. I can squat this way. Well, that's my fault, first off, if you are one of those people, because squatting in the way that I was talking about is a completely different skill from something like a back squat or a more hinge-like squat. So you have to alter the load accordingly. You've changed your strategy, so you can't expect that you're going to be able to tolerate your tissues are going to be able to tolerate the same load with a different movement strategy. Same principle applies to the Jefferson Curl. You might have the prettiest toe touch in the game, but that doesn't mean that you're going to be able to do 225 on the Jefferson Curl, no problems. Be smart and progress load intelligently, and if you do that, I could see the Jefferson Curl being something useful. Awesome question. And I think that's a good stopping point for us today. Thank you so much for tuning in and being one of the fam. You are a beautiful, sexy person. And if you want to learn more, because your boy got a lot of content for you, I got some places for you to go. First, go to your browser. Type in this site, zachcouples.com. While you're there, subscribe to my newsletter, because I got so much free stuff for you. I have this Common Compensations workbook, which is there to simplify your coaching. It's a step-by-step process of coaching specific activities that you are going to apply with your clients. And it breaks down the cheats that you'll see with your clients into 1 and 2 strategies. So it's going to make your life a lot easier. And you'll also get access to my free seminar, Human Matrix Foundations, which helps give you the basic anatomy and all that you need to be successful learning the stuff that I talk about. You also get like 5 hours of talks, free acute to chronic workload calculator, all types of good stuff. I also offer a lot of services. Movement consultation, number one. If you toy, you're not moving as well as you'd like to. You want to work on your ability to perform a loaded flexion, but your toe touch is lackluster. I can help you get your toe touch back. All we got to do is sign up for a movement consultation with me. I will perform a full body evaluation on you. We will find some activities to improve some of the areas where you're restricted. And if I can't help you, I will find someone who will. That's my guarantee. And if I can't make changes in your movement capabilities, I don't charge you. That's just how your boy rolls. So there's that. You could do that from a training perspective. Right now, I have a wait list on being able to train with me because I am filled to the brim with clients, which I'm very grateful for. But sign up on the wait list. As soon as something opens up, I got you. Also, if you want to learn how to apply some of this with your supreme clientele, but you're unsure where to start, and maybe you need a little bit more hands-on approach to help, that's where the mentorship program comes in. You're going to send me stuff of you coaching people, educating people, show me your assessments. I will help be that person who can see you while I'm in the forest, while you're playing in the weeds, doing your thing. That's what I'm there for. Mentorship was essential for my progression as a clinician, as a person. And a lot of us don't have that. I was very fortunate to have Bill as mine. I want to try to extend that service to you in some way, shape, or form. Please sign up for the mentorship program. Once you've scoured ZachCouples.com, then what you'll want to do is search me on Apple Podcasts and Stitcher for the Zach Couples Show. Because guess what, folks? There's 130 other debriefs out there, and I didn't have 2 cameras all the time. I didn't have fancy audio. Well, that's actually going to dissuade you from listening to the podcast. But it wasn't as nice as it is now. So maybe you want to just listen to me on a long car ride. And while you're there, leave a review so the fam can keep growing. I'm also on the social medias. Find me on Facebook and Twitter. Search Z Couples. Of course, I'm on the Instagram, baby. Zach, Z-A-C, Couples, C-U-P-P-L-E-S. And find me on YouTube if you want the most up-to-date activities that I'm applying to my clients. You want access to the debriefs, all that good stuff. That's where you got to go. Thank you so much for tuning in. You've been a beautiful, sexy, outstanding audience. I hope that you keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving. And I'll see you next time. Deuces.